Okay, Dr. Gwon, can you hear us?
Yeah, welcome
Okay,
back.
go ahead.
Here, yeah. My name is Gwon, and cooperating with Dr. Bin Song, my beloved junior faculty, and Dr. Ujin Jang from Seoul Hospital, and he is actually expert in the cardiogenic shock and working with us in the Korean cardiogenic shock working group. He's an expert in that. So very happy to have Dr. Jang here, and he will present today's case.
Yes. Next slide. Yeah, this patient is a 72-year-old male. He suffered from the exceptional chest pain and dyspnea. He was tested positive for treadmill test. On his echocardiogram, LVC source function was preserved, but hypokinesia was detected in imperoseptal apical wall. He has no past medical history. Next slide. This is a baseline ECG. There is no significant ST change abnormal finding in this exam. Next slide. This is a CT coronary angiography performed 2023, August 7th. There is a severe stenosis in left main and proximal to mid LAD with high risk plaque, and there is a moderate to severe stenosis in proximal and mid RCA. Next slide. This is a baseline ECG performed 2 weeks ago. On epicranial view, there is a severe stenotic diffuse and severe stenotic lesion from left main bifurcation to mid LAD. Especially mid LAD was a very tight stenotic lesion with a decreased TIMI flow. And on RAO caudal view, left main trifurcation was a very tight and severe stenotic lesion. We can see it. Now, next slide. This patient was already performed PCI for RCA lesion. He was treated very well using a 2 stent for proximal RCA and mid RCA. Next slide. Dr. Gwon.
Okay, so very ugly looking lesion here from very more than 70% stenosis from the ostium of left main, and especially we have subtotal occlusion in the LAD. The problem is that left main is trifurcation, and LAD is bifurcated. So we are expecting a difficult wiring in the mid LAD, and maybe you can discuss the stenting strategy, 2 stent versus 1 stent. And the problem is how to protect the side branch during the procedure. The actually interesting thing is the echocardiography show the infraseptal hyperkinesia. We have LAD stenosis. That means that the LAD is very large, supplying the infraseptal area, the coming around the apex. So this LAD is a very, very important branch. Okay, what's your suggestion?
So what is your treatment plan, and please suggest your treatment plan, and then we will have a discussion time.
Oh, really? Okay, I just like to wire the LAD the usual way with run-through wire, my workhorse wire, but it'll be kind of a difficult wiring, so I like to use a microcatheter. Problem is that the left main LAD is the kind of a tight stenosis. Maybe the flow will be compromised. So I think our plan is to dilate LAD2 left main with a 2.5 balloon, then use a microcatheter, then wire down to LAD and see what's happening. And actually, this looks a very ugly lesion, but if you look at it very carefully, the side branch ostia were not so severely diseased. So previous.
This is a diagnostic angiogram. What is you will do the femoral angio or radial angio? What is the size of the guiding tester?
Yeah, actually, again, so the diagonal ostium, circumflex ostium, and the ramus ostium is not so severely diseased. So I think we can end up with just one stent technique. So I chose a transradial approach with a 6 French.
Okay.
Maybe some of you are uncomfortable with the 6 French, and in my series, most of it, over 90% of cases, so I do 6 French without the large bore using rotablation.
Can you show us a spider view?
Spider view.
Next slide.
Next. No spider view now.
In the angiogram, in the AP cranial view, in the left coronary angiogram, is some educational purposes. Look at the left main. You have the left main disease, correct. And when you look at the size of the vessel and the distal LAD and the big diagonal branch, look at the size of the vessel and then compare the size of the vessel in the left main. It means in my eye, the left main is a very, very severe disease, even in the angiographic appearance.
Yeah, sure.
Okay, go ahead.
So what's the planning? So I
Please
try
show
to
us,
finish with just a one wire sequential ballooning.
Please show us the
that okay for-
fluoroscopic image.
Okay. So the first
Today's
angiography.
angel, please.
제일 처음.
Okay.
Okay. So
처음.
그전.
제일 처음.
As you can imagine, that the guiding catheter is damped, even with the 6 French guiding catheter. So we just very carefully.
Is there a side hole or
No, I
non-side
don't
hole?
like side hole. I don't like side hole because I can control the guiding catheter with the wire. I'll show you next time.
Okay, it's
So,
up to the operator decision.
Right.
Okay.
So, yeah. Okay, wire into LAD in the spider view. Next. So wire in the septal branch. Then I control the distance between the guiding catheter and the left main ostium and take the angiography. Okay, then next. Anyway, we need a wire for the ramus branch. So I rewire to the ramus branch, then take the angiography, epicaudal. Maybe you need I'll check the spider view next time. We didn't check it. Next. So I dilated LAD2. Next. To guarantee the flow, the outside of a microcatheter. Then I installed the microcatheter, the Corsair, extra small, with the run-through wire. So please look at the wire in the obtuse marginal is the wire pro left down there, and I control the distance between the guiding catheter and the left main by pushing the wire and pulling the wire. This is a very easy way without the side holes in the guiding catheter. So,
Okay,
next.
go ahead.
Yeah. Next, and the wires inside of the LAD. Then I push the microcatheter inside of LAD ostium. Next. So this is a process of wiring, not real actually. It is a little bit difficult because very tight lesion. This run through wire, but with the help of a microcatheter, it's kind of easier to cross the lesion. Without the microcatheter, actually, we have a lot of difficulties to cross the lesion with wire. Okay, next. Okay, wire deeply. Next. And actually, Dr. Song suggested that we need to cross the microcatheter down there. That might be to spare us from using a 1.5 balloon. And I'm not sure, but he said that. He told me that, and I followed it. But there was a resistance in crossing the Corsair microcatheter. And finally, we got through it and pull out and take the angio. Next. Okay, still we don't have enough flow for the LED. That's here we are. So any suggestion? Or we are going to dilate LED from LED to left main, 2.5 loop. 2.5.
This image is so far the final,
Yeah,
the
fine.
angio. Okay, keep going.
Yeah.
Coronary plaque is mostly located opposite side of ostium, diagonals,
Yeah.
and circle.
Right. Yeah. That's why I prefer to use just a one stenting without even wiring the diagonal. Recently, I don't like to wire the side branches that have which have no disease in the ostium. It will complicate the procedure.
There is a huge plaque burden, so you don't worry about no referral?
Yeah, but there is no other way, right? Test it.
Test it.
Okay, going in. Resistance. Okay, here, 6,
What size of the balloon?
2.5, 20 millimeter.
Okay.
10. Okay. Deflation. Then I'll check the flow, test.
Test.
Still competition flow maybe. There is still angio.
네.
There is some dissection.
Yeah, dissection, and the lesion should not be very long. After 2.5 is too large for this patient.
No, plaque burden is too much.
Right. Yeah. Okay. So
I think
got
this
to
kind of the dissection is some therapeutic.
therapeutic, right? I hope so. Ibis.
Please show us demonstrate it.
Demonstrating means that you hope I make a mistake.
Never.
Big dissection?
Test it.
One of the option in this kind of situation is what is the real vessel size. So the imaging study is very helpful. The second
yeah.
the purpose of the imaging is to evaluate what is the status of the ostium of the big side branch vessel. Is the disease involvement or not, mild or severe? So if there is no
Really,
severe
really?
involvement of the disease in the ostium of the side branch, we can fix it just a simple technologies. Simplest.
Okay. This time. Let's
네,
close. Okay.
하겠습니다.
Pull back from the size is about 3.
What is
a
that?
little bit larger than
Ibis
3.
image.
Ibis.
Please show us the IBIS
okay.
image.
Stop.
It is not.
Ibis screen. Ibis on the screen.
No.
Ibis.
Please do not pull back it. Hold
Yeah.
it. Okay. We can see that.
Okay.
Go
okay.
ahead.
On.
You on live.
다시.
Yeah. Start pull back. Vessel size is around 3. Lumen size 2.5. It's a small septors coming in. This
huge
is a
block.
totally subtotal occlusion.
Dissected from the 6
Dissected,
o'clock
right,
to the.
yeah. Right. Deep
And the distal
dissection
vessel
is,
size
5
3
and 4 o'clock.
is not a real vessel size because it was totally occluded. It's a little
Right.
bit shrinked.
Yeah.
Plaque burden
But
is
I
huge.
already gave the nitroglycerin
1, 2,
about
3, 4.
5 minutes ago.
Actually, the vessel size in here is 4.
Right.
It's a big vessel.
Yeah.
There is a wire is coming at the 3
yeah,
o'clock.
circumflex coming in. Left main eye.
Main size is 1, 2, 3, 4, 5. Almost be
About
more than a
5.
5.
5.
But the
Yeah,
angiographic
this-
appearance less than a 2. It means that the underlying
Yeah, to the
severe plaque
ostium.
burden.
Okay.
So,
But
and
the
then
Theo stent
based on
is
the
a
IBIS
little
image, what
large
is
for the
your
LED.
plan?
So what's your plan actually? So how about the size of stent? 2.75 is preferred or 3.0? Usually I select 2.75, considering the plaque burden, and vessel size is 3, lumen size is 2.5, but I try to use 2.75.
One of the option
what's
is
the
the administration of the intracoronary nitrate, and wait
already
for
given.
3 or 5 minutes, and then we will realize the real vessel size.
Actually, nitroglycerin was given just 5 minutes ago. So this is the real size.
We have two options. Is that the stent size is the match to the in the distal vessel, and the proximal one is a post dilate. Second option is we intentionally select the more bigger size of it. What is that? The 3.25 stent with a still under
사이즈 길이를
implantation.
이걸로 재볼까? 와이어로?
탈색 있어서.
Oh,
Why do you?
스탑?
What is the
Lesion length.
purpose?
엔지오?
dangerous.
Shut? Dangerous, of course. But you can do that.
It is some
No, don't
dangerous,
think.
really dangerous.
오,
탈색
yeah,
있어가지고.
와이어.
This is dissected lesion.
Dissected, right.
Safety
Sorry.
first.
Usually I pull out the wire to measure the length, but that may be not a good idea in this patient, right? Yeah.
Okay.
Okay.
Just to make history.
Yeah.
The message from this kind of technique is don't do that, never. It's a message from the operator.
You got the point. Anyway, the angiogram.
찍은 거 랭스 좀.
그다음. Okay, stop. So the radiopaque part is 30 millimeter, right?
Yes.
30.
I think
Anyway,
the
we take
length
the
of the
first
stent is not important. The size of the stent is more important.
Yeah. So I prefer 2.75. What stent? What stent? Synergy stent. I like to use a synergy stent because this is quite flexible in sizing. The higher pressure, the kind of a more compliant than the Abbott stent. So maybe we could start the 38,
Okay.
2.75 synergy.
Angiographic appearance in the arcing of the diagonal branch is quite preserved. So in this
Yeah.
kind of cases, we have a more comfortable to cross over the diagonal branch with the stent.
Every branch osteum is okay.
발색실 쫙 만들었으면 또 신났을 텐데. Okay. Let's
What
see.
is the length of the stent?
Yeah, 38.
38. It's a
Yeah.
2.75.
2.75.
2.75, 38.
Because
Synergy
I
stent.
was finding the size of the vessel is the
30.
distal to the diagonal branch is 3.0, but the proximal
Right.
to diagonal is 4.0. Some size discrepancy. So in that
Yeah,
case, maybe shortening
Yeah.
the stent length.
Shortening.
Yes,
don't think
select
so.
because of the just above the diagonal branches, vessel size is a bigger one.
Shortening, I'm not sure. The recent
It's
version
up to you.
of DES. Of course, it's up to me. I'm in charge here. Tester?
Okay.
No, tester?
Too deep, too deep.
지가 안 보인다.
잘 안 보이지, 그지? 천천히, 엔젤 천천히.
네.
Sure. Maybe you can wait until
Even though
the
you
branch is
dilate
coming.
the proximal
Okay.
part of the
So-
part of the stent is maybe 3.5,
French.
but
Yeah.
you know,
Yeah,
anyhow,
여기
2.75
diagonal,
is
diagonal branch.
maybe small in the proximal
Inflation.
LAD.
8.
8.
We identified the small diagonal, so we identified the location covering 10,
10.
12. Okay.
So maybe for the audience, what usually helps in these cases
like-
if you have diffuse disease in the landing zone to go on live IVs when you start the pullback. And You see here in the first frame of the pullback, there is already a plaque burden of at least 30%, but it looked indeed like if you would have gone a little bit deeper with the IVUS catheter, that you maybe would have been better able to appreciate the true size of the vessel. In this case, you end a little bit in the plaque.
Angio?
And then if you store the position of the lens of the IVUS, you have your landing zone marked.
Ostium, Leo?
Yeah,
I
in
cannot
this
see
situation,
clearly
it's
the
almost
ostium of left
proximal
main,
LAD.
so
The
I
size
choose
is
the Leo.
relatively small.
Leo?
2.5 is the proximal
Cranial
LAD.
Google
Is
test?
You will dilate it with a bigger
Okay,
size of
this
the balloon.
Angio 준비?
네.
디지털 잘 안 보여요. 잠깐만.
안 보여도 돼? Sure. Okay. So issue here is how can I identify the real ostium by the angiography? The most of them is we can check it in the epicranial, and many others we are still just LAO view. You can clearly see the ostium of the main. The stent is there. We got the ostium of the left main. So previous view. 고정 view. Okay. This is a 38 exact location.
Half side.
Half of the 38 16,
20대입니까?
20 maybe.
You know,
20.
you know, to be careful over the left main bifurcation. You know that the proximal margin of the stent almost be in the left main bifurcation. So there is a chance of the 2 layers of the stent strut in the left main bifurcation. It means that the possibility of the
overlapping in the proximal LAD actually. So 20, 3.5.
5.
Proximal stent is then this bifurcation. LAD. Yeah, but little bit distant. What size do you choose?
Yeah, 3.5, 20. Based on the length of the balloon. So we see clearly the ostium of the epicrania. So it should be going in. Then pull back. Tester.
테스트.
This overlapped. Here. Okay, Leo. Okay, test.
테스트.
조금 작다.
네. 조금
I'm pushing the wire in the obtuse marginal to get the distance. Test.
테스트.
지금 괜찮고
오케이.
커버가
Angio. 짧게. Sure.
위치는 딱
Just a little bit proximally. Pull it back. I'm not pushing the wire together. Okay, test.
테스트.
Okay, test. 뷰가 아까 같은데?
네.
좀
근데 이게
겹쳐 보이는데?
가이딩이 떠서 하는
약간 cranial. Cranial. Test.
테스트.
Okay. Test. Okay, nice. About 2 millimeter outside the left main. Epicranial. I'm not sure this is overlapping the main stent. Just
스탠드
stent booster.
스탠부스터.
Maybe we just have 1 millimeter overlap.
오버랩 있지 않아?
too much accurate maybe not helpful for the when during the inflation there is some chance of the some movement of the stent unpredictably. So maybe the some chance of the loss of the left main arch.
Sorry, we have to change you 24.
약간
You need some safety margin.
Right? Yeah.
저랑 될것 같아.
Okay.
아이 조금 넣어도 되는데.
Maybe in this epicranial view, actually, the balloon marker is not covering the left the main ostium. That's why we have failed to measure the stent length. So nobody is interested in the wiring the diagonal or another branches.
So I'd like to question one point. And do you usually do the stent implantation and without predilation? I think in predilation, direct stent is usually good. However, sometimes it's quite difficult to accurately stent a position without predilation.
Predilation for diagonal or LED?
Left main. You just left main and proximal RAD, and you didn't do predilation.
Yeah. Dr. Hong, please answer the question.
Okay, let's see what happened. Is that the maybe result tell us how can we do?
Okay, inflation. 5, 8,
Slowly.
10,
Okay,
Okay.
excellent.
cranial, 12.
And then we will try to find what is the fate of the side branch vessel. Actually, the
Deflation?
mother vessel was the very excellent
epicordal?
treated.
No, epicranial. Just stay there. So I like to dilate further with the same balloon, the part for the above, just above the diagonal, so-called the sequential part. Test. Part, the proximal end of a distal marker is just aligned with the carina. That's the rule. Test. A little bit more deeply. Test. Test.
That is a stent balloon,
Test.
delivery balloon.
Test and balloon.
Stent
Right.
balloon.
Test.
Stent balloon.
Proximal stent balloon.
Yeah. Inflation.
lesion,
10.
10,
14.
18,
Okay. This is the first part. Deflation.
lesion,
에피코덜. 잘 지키네.
스캔 부스터가 메인
테스트. Okay, here, inflation. 10, 18.
18,
Anyway, we need further part NC balloon for the left main deflation.
lesion,
But just in case, I do routinely pop left main before removing the balloon. So, okay, let's see. Theoretically, actually, the plaque is the opposite side of a side branch, but we have a carina shift sometimes, and not real life is following the theory, right?
So far,
As to change.
result is so excellent. What I mean is that the before the starting at the PCI, the angiographic appearance really ugly appearance. But
Right.
so far he fixed it just crossover single stent technique is the very excellent.
Actually, we have a very severe SD change. You can see that. Test. Flow is okay. 가슴 아프세요? 지금 가슴 아프세요? 좀 답답하죠, 그죠? Yeah, he has a little chest pain. Maybe slow, maybe. As you, Dr. Hong suggests, we have a SD change in the leader 3.
Really?
Let's check. Yeah.
There is some ECG change.
You see
It means that
change. Can
the
you show?
very tightest lesion you dilate very aggressively. So the result is excellent.
Really?
So the patient feels the chest pain is so
Yeah.
natural.
Please show. You cannot see the EKG, the vital sign.
심전도 좀
Now it's time to check it. There is some loss of some side branch
Yeah,
vessel or
sure.
not.
EKG first. EKG.
Can you
Side branch looks okay, but maybe some plaque embolization.
That is another
Yeah,
possibility.
yeah,
Right.
yeah. EKG?
심전도를 이걸 카메라를 이쪽으로 보내.
Yeah.
오케이.
Until the EKG is ready, I'll check the angiography.
Yeah.
Okay?
Why don't you give verapamil and adenosine?
Yeah, angio first. Epicranial?
원래 약간 모양이.
원래 그랬나?
아, 예, 한번 보겠습니다.
Anyone remember the first EKG?
첫 ECG 한번 봐주세요.
Okay.
If there is no loss of the side branch vessel, I think this case is the angiographically is okay, but the ST elevation is the observed. It means the Dr. Lee comment that the possibility of some plaque microembolism might be related with such kind of the ST elevation.
There's some slow
can
flow
see.
many septal branch, so probably plaque
It's
embolization.
possible. Plaque embolization usually you can see in the LAD.
베이스라인. 아, 좀 확실히 바뀌긴 바뀌었네.
Yeah. Can you see, 이거 못 보여주지? Yeah. In the baseline, I am looking at the baseline EKG. There is no ST depression. In the lead 3인가 저게?
네.
And lead 3.
Actually, this one is
yeah.
the baseline. and
This is
one,
baseline. You can see baseline EKG. You can see no ST change in the lead 3. But currently, 다시 처음으로 바꿔주세요. ST change. That means there is something happening.
This is definitely ischemia. So.
It could also be the ostium of the diagonal, right? I mean, it's mainly ST elevation in lead 1. Maybe some more lateral. There's TME3 flow, but
But it is coming back, I'm sure.
Okay.
Yeah, let me show you the IVUS.
You don't give verapamil?
Oh, I
No?
didn't. No.
Sometimes
Maybe if you
helpful.
like, I 니크란딜 좀 주세요. You use a 니크란딜.
Yeah.
니코란딜?
니크란딜.
이거.
Okay. Can you see the IVUS? Looking at the IVUS, right? Okay.
연결 안 됐잖아요.
Yeah, I think it's well expanded over 3.0. At 3.5 balloon. We didn't do the part in the left main.
Yeah.
Okay, trifurcation LED very expanded.
와우.
So maybe around here is overlapping. It's very difficult to locate the overlapping in the IVUS because the senior stent is very thin.
Yeah, right.
Is that right?
Yeah.
You like sinners. Okay, stent left main. Still 3.5 maybe. Do you want me to go with this is stent 1, 2? Yeah, just 1 or 2. Just 1 millimeter outside of LED.
Excellent.
So, yeah. With the angiography, actually, there is a lot of techniques to precise location of the stent in the ostium, but the good angiographic view, I think, is very easy to locate the stent exactly there. So, 니크란딜 좀 주세요.
니코란딜.
Yeah, we have nikrandil. So, verapamil, we have sometimes bradycardia. 천천히 줄까?
아니요, 이거 그냥 빨리 주는.
Nikrandil, we use it in FFR measurement and also for the slow flow. Let's see. So we cannot see the slow flow in the LED itself, but we can see what's happening in the EKG. Okay, meanwhile, 4.5. NC below for the left main.
4.5.
Yeah, it looks much better.
Yeah.
It started very ugly in geography. Now it looks quite nice. A spider view. Let's
So
see.
far,
Let's
the
look at
angiographic appearance is very
Yeah.
excellent.
Spider view.
4.5.
Spider view.
응.
불을 돌려달라고. 스파이더 뷰 찍은 적도 없어요. 우리. Spider
일단
view.
그걸, 저.
Okay. So look at the circumflex ostium. The spider view is best. Angel?
Okay.
Sure. Okay. What do you think? Maybe we can, after part, you can rewire the circumflex and get the image from it.
Circumflex
Okay.
ostium is always
color?
unhappy.
It looks unhappy, but
Crying.
I think crying.
Angiographic appearance of the circumflex ostium is quite narrowed, but flow is okay. So I think it's so far is a very good appearance, even though the
Epicodal?
morphologically narrowed.
I am not a physiology guy, but if I check the FFR here, I'm sure it is more than 0.8. If you like, I can show you a test.
됐어?
Okay, inflation.
그래서
Most of the interventionists know that the TIMI3 flow, it means that the
16.
FFR value more than 0.8. So you don't need it.
Deflation.
I have one question. Is Ramos guidewire
Inflation?
outside of
Inflation?
left main stand?
Yeah.
16.
It's not a problem.
Is
There
Ramos
is no severe
guidewire
calcification
outside
here.
of left main stand?
Right.
Yeah, protected
Inflation.
wires.
Do you want me to remove the of this marginal wire? Let me show you. This is the wire, and I pull back. Yeah, no resistance, right? No is this is very. So I cannot remove it any time. So maybe I can remove it now. You happy with that? Angiography? Sure. Okay. So maybe I can rewire the obtuse marginal, then check the ibis. Maybe wire is a little bit damaged here.
Now you're trying to the rewiring the obtuse marginal.
Yeah,
What is
to
the
show the
purpose?
ibis. Because I like to show the ostium of the circumflex ibis. This wire is damaged actually. I'm not sure I can do it with this wire. So, spider view. Tester?
Yes.
Okay. No. Oh, epicodal.
Very
That's why I
cooperable
love a run-through
wire.
wire. Cover retention is very good. Right? Tester? Okay, not exactly.
Small branch.
Talk. No, not that easy, right? Talk.
Personally, I think you don't need to show it the
Ibis?
obtuse marginal branch with the ibis. So far,
Yeah,
the
have some
current
fun.
result is quite
Tester?
good.
Spider view? Maybe
After
I need a
wiring
blue wire.
over the obtuse marginal branch, if there is some resistance crossover the stent shroud in the obtuse marginal, and then
Yeah.
at that time abandon.
So how many minutes do I have? How long do I have?
You have enough
wire
time.
새로 좀
네.
You have
Run
almost
드릴까요?
18
시험.
minutes.
런 와이어.
How many minutes?
10 minutes.
18 minutes.
런스루 하면 돼.
18.
I have one question. Can
You
we
have
include the
enough time?
QFR of the circumflex post-standing?
I have 18 minutes? Really?
Because
Enough
the
time.
Dr. Kang in the Bundang Seoul National University, he
Introduce.
showed us the very clear and the informative cases with a
finish
very
the
short
procedure.
duration.
So he did the FFL and QFL, and do you want me to check the FFL for obtuse marginal?
It's up to you. We have a time.
We have time. FFR 준비 좀 해봐. Yeah, I'll try FFR. And IVUS and FFR, that's the purpose of a live demonstration. Usually I don't do that. For your record,
Where is the wire?
Here, test. Okay. Okay.
맞는 거 같아요.
good.
에피코다.
테스트.
오케이.
오케이. 지금 아이브스 한번 하고
네.
마이크로 카테터로 익스체인지.
네.
SFR 준비.
네. 아이브스 먼저.
오케이.
서클.
서클.
네.
Dr. Hong, do you think this every stent crossover across this major side branch is okay? Stent crossover over major side branch, do you think it's always okay? But some patient present with this stent-jade thrombosis.
Yes, that's true. That's true. But the most of the case for me is that free flow.
스트롯은 열지 않아서.
Maybe there is some nidus in the during a long-term follow-up, but something
우리 안
happened at that
하시는데.
time. Several years later, at that time, I tried to fix it. Not
앵글이 약간
immediately.
엇비치해서.
Several years ago, this diagonal branch was clear, stent crossover, but 4 years later, presented with ventricular fibrillation. Coronary angiogram shows stent-jade diagonal branch was still total occlusion, but purely thrombotic occlusion. So
경기 때문이 아니라
I think stent crossover is not always
너무 무리하진 않아요.
safe.
There is some such kind of the possibility, but if we worry about such kind of possibility, so we try to fix all cases of it. Is another different scenario.
Can I ask a short question from the panel? He put the 2.5 stent in until around the proximal LAD to the distal LAD, and he dilated the proximal part with the stent volume 3.5. So generally, we can get the even though we dilated the 2.5 stent with the burst pressure 2.7 or 7.5, 2.75 is the maximum. So it looks okay, the immediate integrity, but are there any concern about the integrity of the small stent and the bigger balloon? Do you have any question? Do you have any idea about this? My questions.
네, 적었습니다.
It looks like almost from the iris around the dilate around the 3.0.
I think it depends on stent type, company.
If there is a resistance, don't try too much.
Yeah. I know. 또 테스트 좀 해볼까요?
네, 테스트.
There is two possibility. The damage to the stent strut. The second one is that when you pull back the iris catheter was packed by.
Okay. So pressure your stop. Yeah. Maybe.
Personally, I think it's the current result is excellent. So if the patient is my patient, okay.
Yeah.
I'm happy about the final result. Just let it alone.
ST
follow.
좀 좋아졌습니다. 테스트. ST도 많이 좋아졌습니다.
Please show us the EKG. EKG on the screen.
Oh, still it's the depression.
Yeah, still it's a depression, but it's getting better.
Yes.
The QRS
As the elevation in
size
the
is
lead
smaller.
one was resolved.
Yeah.
Yeah.
Okay. Test.
테스트.
I already removed. 가이딩이 좀 빠졌다. 잠깐만. 가이딩 포지셔닝. Okay, test.
Dr. Pyun, the comment about the treatment method of Dr. Gwon is the old-fashioned.
What
So
is the new
do
fashion?
not follow this one. Is the expert the way of the fix it. Is that he had a lot of experience. Just do it. If you think you are a beginner, you have to be a classic.
What?
못 들었습니다.
I'm doing the old fashion.
Yeah, it's up to you. Nobody blame
Why
about
did it help me?
your way about the PCI procedure.
Actually, I am still working on the Korean bifurcation club, and I think I am doing the most the contemporary ones. Actually, we talk about crossing the stent across the circumflex. Actually, this is a very the important task for the Dr. Nam in Gyeonggi Dongsan University. He published the paper already. There is no the outcome difference between crossing over and the side branch opening. Actually, EBC traditionally insists that opening the circumflex ostium is very important for the long-term outcome, but in the real database, actually, it never proved. And actually, Dr. Nam is working on the random trial comparing the crossing over and the opening the side branch. Actually, so I'm very comfortable without the side branch opening. Okay.
네. Fine now.
Enjoy.
예.
Shoot. Okay. Spider.
When you see the AP or area caudal view in the
Yeah.
post PCI or pre PCI,
네.
the angiographic morphology is dramatically
Okay.
changed.
Epicranial. Actually, it looks a little bit compromised in this view, but Dr. Gu, year 2005, already showed that the FFR looks much better than as you looking at the angiography. Just the pinching, shadowing of the stent struts across the circumflex ostium. I'm definitely can say that. Sure. This is there is no problem with that. Okay.
Good.
Can you see just one wire, just two wire? Actually, I don't think that the wire in the obtuse marginal play a role.
No.
So usually in my practice, just one wire, one stent technique ends up the lesion. Even if you are looking at the very ugly structure of the trifurcation, bifurcation, you can finish with a very simplified version of the stenting technique. Okay.
The procedure itself is educational and a very dramatic result. Congratulations. For the young generation interventionist, don't follow his way of procedure. It's dangerous to you.
No.
It's only for the up to him. So as you
Really?
see, for measuring a stent length, pull back of the wire is clearly show that it's dangerous too.
Okay, I agree. I
anyhow,
agree with that.
I would
Yeah,
like
I
to
agree
say
with
that congratulations. This result is very excellent and very informative in the most
Yeah,
of the
thank you for that.
participants.
But I like to insist that my strategy is not about the technique, but the strategy, right?
Right.
So you can follow me.
Any comment? Even though we have a time, there is no comment. I'd like to close this session.
Okay.
Any comment?
Thank you.
Very nice result.
Yeah.
Okay.
Congratulations.
Okay.
Congratulations.
Thank you very
Excellent
much.
result.
Thank you.
Thank you.